Hello, good morning, good afternoon, good evening, wherever you are. Welcome to this session. What does it take to build accountable community health systems at scale? So just give our attendees a moment to trickle into the room, and you're very welcome here. So we're looking forward to a great session. All right. So I'll begin. Rude or indifferent treatment at health facilities, medicine stockouts, absent personnel, demand for informal payment, unresponsive management, and unfulfilled promises. Accountability failures in the health sector are well documented in academic literature and popular media, and are experienced firsthand by millions of people every day. These failures violate patient dignity and rights. They erode the citizen-state relationship, and they lead to preventable morbidity and mortality. There's no shortage of small-scale pilot projects introducing committees or scorecards or supervision programs in communities or at a few facilities seeking to bolster frontline accountability. There are some exciting success stories, but very few have shown sustainable or deep change. The evidence ultimately suggests that accountability is a systems feature, and focusing only on behavior at the front lines is insufficient. Some even suggest that this focus on the front lines can be unjust. But what works to build accountability at scale? To create systems wherein the interests and oversight of healthcare providers, clinic and laboratory staff, pharmaceutical and equipment suppliers, managers, bureaucrats, and elected officials are all aligned, and the supervision is rigorous enough that it ultimately serves the interest of citizens. We're going to hear from 6 researchers today who bring examples from diverse settings or present frameworks and evidence mapping to help us navigate this fundamental health policy and systems question. Before we begin, I'm going to release a poll question to get everyone engaged and started. I'm actually releasing both of them. There's 2 questions now. And we're asking, have you worked in any accountability in health services initiative as a professional? So have you done any research projects that were accountability oriented, or reviews of literature, or any professional projects that are linked to accountability, just to get a sense of who's here. And then the second question asks, have you participated in any accountability in health services initiatives as a citizen? So have you yourself been involved in attending meetings or engaging in any sort of oversight or accountability initiative? And you can interpret this idea of an accountability in health services initiative as you would like. And we can discuss in the discussion period what this really includes. So we have so far 100% yes for professional and 100% no for personal. It's just switching around. I'll give people a chance to reflect and add their vote. Even our speakers are welcome to vote if you'd like. And it's also interesting to see we have a vote for unsure or other as well, which is, I think, going to be fruitful in our discussion to sort of think about what counts as accountability work and what does not. All right. So I think without further ado, we will turn to our presentations. Our first presentation is by Prof. Jose Patricio Bispo Junier, and he is talking about health councils in Brazil, realities and challenges to increase social vocalization and accountability. And we'll go ahead and watch his presentation now.
Hello, my great tall participants in the 6th Global Symposium on Health System Research. My name is José Patricio. I'm from Brazil. I'm a professor and a researcher at Federal University of Bahia. I'll present my work, Health Councils in Brazil, Realities and Challenges to increase social vocalization and accountability. I'd like to begin by talking that social participation has assumed great relevance in the health system of many countries. In Brazil, we have the health councils. Health councils are institutional mechanisms for social participation in the Brazilian health system. There are health councils in very government level. In each municipality in Brazil, there is a health council, just as there are state health councils and the national councils. I'd like to highlight two main characteristics on health councils in Brazil. The first is composition. The councils are made up of half on the participants of civil society representatives. In Brazil, they are called user representatives. As we can see the figure, the other half of the representatives are policymakers and healthcare workers. The second is about the attributions of the councils. The health councils are responsible for approving and monitoring health policies. Our aim has investigated the power of influence of civil society participants in the political decision-making process in health councils, in the performance of these councils, in the increase of accountability. About methods, the study was carried out in their towns in Bahia State, Brazil. We selected cities with different sizes. Consider the number of inhabitants. A small town, Nova Canaã, a medium-sized site, Itapetinga, and a populous city, Vitória da Conquista. The data sources were analysis of documents, direct observation, and in-depth interviews. We analyzed regulations and meeting minutes. We observed 18 meetings of health councils, and we interviewed 21 user representatives, 12 health professionals, 10 policymakers, and 6 service providers. For analysis, we developed a theoretical conceptual framework with 2 dimensions: community engagement and accountability. Researchers at Committee of Federal University of Bahia approved the study. Everyone signed the free and informed consents. The results. We identified a relationship between levels of performance of the dimensions and the population size of the towns. In the community engagement dimensions, we identified a great popular participation in the most populous town. The health councils holds regular meetings, high participation of civil society, and in-depth discussion to improve the local health system. We identified that the Council is a powerful instrument of social vocalization, thereby enable the inclusion of important issues on the political agenda. In turn, in the smaller sites, we found a decreased social engagement and the empty of councils. In the accountability dimension, we found that the 3 health councils maintains a regular practice of approval of budgets and rendering accounts, which has proved to be favorable to accountability. However, we identified that this process takes on a bureaucratic connotation due to the legal requirements of the health system. In conclusion, health councils allow the expansion of social vocalization in the power of influence of civil society in the Brazilian health system, although with heterogeneous performance among the towns, especially the size towns. The accountability mechanism have proved to be strength for health councils, but they need to be intended for a more effective control over healthy budgets. We highlight the need for empowerment of population, especially in small towns, and greater transparency in the execution of healthy budgets. Is there? Thank you.
Thank you very much, Jose Patricio. Just to note to those who have joined us more recently, welcome. There's a poll question that still is open, so please feel free to weigh in. Don't hold back, and we also don't know who's saying what, so feel free to just be honest. We're going to hear from all 6 of our presenters one after another, and then have our questions and discussion at the end. So as you're listening, if you think of a question specific to the presentation you're hearing, do feel free to go ahead and type it in while it's on your mind, so you don't forget, and so that the people who present earlier also get the questions at the end. So we'll now hear from Dr. Emma Sachs, who will speak about Beyond the Building Blocks, integrating community roles into health systems frameworks to achieve health for all.
Hi, everyone. Thanks for joining. I'm here today to talk about some efforts to expand the building blocks of health systems to better integrate communities in order to achieve health for all. I want to thank the very large group of people that's been involved in this. My co-authors are listed here, and the full paper from which this work derives is also listed at the bottom. So we know that community health is essential for improving population health. And we know that there are certain aspects that are really important for community health to be effective. We have to have a continuum of services, and that includes a continuum of providers and across settings. So both from community to facility and back from facility to community, these need to be well coordinated, sort of seamless as possible across the settings. We know that we need strong collaborations, especially to reach the most underserved, and often these efforts have to be deliberate rather than passive. We know that we need reflection and learning, and we also need iteration. So not just collecting data at the community level, but using it to improve services and programs. So I'm sure many people are familiar with the WHO building blocks. They're listed here. These are the pillars that are often used for describing the various aspects of a health system. And although they weren't necessarily intended to be used for resourcing and decision-making per se, that's often now how they are used. And so they're a very good starting point for thinking about the various aspects of health systems that need to be considered and strengthened. However, if we take the definition, the WHO definition of a health system, which is that it consists of all organizations, people, and actions whose primary interest is promoting, restoring, or maintaining health, then we have to think beyond the formal health facilities themselves to the various actors who are also interested in health promotion, health care, and that includes a number of different community level actors and how they interact with the formal health system as well. So we undertook a number of different activities, starting with a review of frameworks for health system strengthening and health systems guidance. And we found that many of them lacked any references to communities, and those that did often lumped them together in a sort of more nebulous concept of context or population or even culture. And when a sort of expert panel was organized back in 2014 to consider the role of community in health systems models, it was concluded that by kind of having community everywhere in a very abstract sense, it really wasn't explicitly anywhere in any of these guidance documents. So we undertook a long participatory process for kind of reconsidering the building blocks and how communities could be better built in a more explicit way, and the roles of communities. So a number of consultations were held at international meetings. The various versions were circulated and iterated, I would say, among various consortia and partners that worked on this. And a presentation was given for final feedback before publication as well. So this is the expanded framework that we proposed, which we've called Beyond the Building Blocks. And as you can see, the original WHO building blocks are all here in this kind of beige color, which are super important for thinking about the components of a health system and are very widely used already. So kind of easier to build off of those existing frameworks. However, we really wanted to make it clear that the goal of a health system is to produce healthy populations and healthy communities. So you can see that box up at the top. These aren't sort of processes just for improving a health systems for a health system's sake, if you will, right? So keeping that goal in mind. We've also added here a few boxes kind of representing the health determinants that aren't always considered when we think about health systems and health facilities. So we have boxes here for social determinants of health, which I'm sure that many people are aware of and have worked on, as well as household production of health. And we started this process of thinking about this model, especially thinking about maternal and child health. And we know that a lot of the primary care, especially of sick children, happens at the household. So this becomes another really important place to be thinking about as far as strengthening and maintaining health services. The purplish or bluish boxes are those that have been added or expanded. And so in some cases, they're kind of new. And as you can see for service delivery and health workforce, they're just a way of making explicit that the service delivery components and health workforce components occur both inside facilities and at the community level, and often need sort of separate guidance, separate resources, whether these services or these health workers are sort of directly employed or supervised by the Ministry of Health or the government. they may need sort of more harmonization, more standardization, certification, accreditation, et cetera, even if they're being delivered by partner organizations or others who are involved. The added components here around community organization. So maybe their main focus isn't always necessarily around health, but they're very involved in some of the health activities, and being able to have those organizations around the table when decisions are being made about the health system is very important. We also have societal partnerships. So again, thinking outside of the health sector. So this might be working with the education sector, the agriculture sector, right, beyond the sort of traditional health components or health system areas. Finally, information and learning was there, but we also wanted to emphasize the piece about accountability, right? So taking those data and then using it to really share back with the community, improve those programs, and kind of continue to build better systems. So in conclusion, we think it's super important to keep moving sort of beyond the building blocks and build kind of more and better inclusive health systems. We think that this keeps the focus on healthy families and communities. It provides more explicit attention to communities, not just as passive recipients, but as leaders and partners in health system strengthening efforts. It recognizes a bit more of the kind of local knowledge and capacity. Communities can often be more adaptable, for example, when there are outbreaks or other crises. And by having communities lead the process, it can be much more sustainable. Communities are foundational for achieving these global health goals. And we recognize that this is sort of part of a continual iteration, and that the frameworks we use and the guidance that we create and share will continue to evolve over time. So we look forward to having more and better community involvement in future frameworks, hopefully at the next Health Systems Global Symposium.
Thank you, Emma. I don't know if others couldn't help but look at her framework while thinking of Jose Patricio's health councils in Brazil and start thinking, oh, how would they fit into each of those new beyond the building blocks components she highlighted to us. So that was really, really exciting to see that framework presented. So I would now welcome Ms. Kamanwan Kiaunin, who will speak to us about citizen participation in governing Thailand's universal health coverage scheme. Also, just to note that people are introducing themselves in the discussion. So please don't be shy. Let everyone know who you are and where you're joining us from. All right.
Hello from Bangkok. My name is Kamanwan Kiaunin from International Health Policy Program Thailand. Today, I'm going to present the research article on citizen participation in governing Thailand Universal Coverage Scheme. Citizen participation in policy decision-making process is a key component of good governance. There are many challenges for low-middle-income countries to move toward USC, including grappling with the integration of the USC agenda within the national policy and the sustainability issue. In case of Thailand, we have the National Health Security Act 2002 that provide legal space for civic participation in governing the Universal Coverage Scheme. The Article 13(4) and 48(8) mandate the representation of civil society organizations as a committee members in the National Health Security Board and Quality and Standard Board. There are 5 CSO representatives for each board. This research is a lesson learned from Thailand that aims to analyze the implementation of the legal provision on citizen participation and its outcome in Thai UC scheme. This research is qualitative research by review literature and relevant documents. Then we use in-depth interview method. There are 10 key informants who are the CSO representative on the National Health Security Board and the Quality and Standard Board. The data was collected for 2 months, from October to November 2019. The research found that citizens actively participated in 3 functions of the governance of the UC scheme. The first one is participating in the decision-making and governance through representation as committee member. The second is supporting the decision-making process through representation as subcommittee member appointed by the 2 committees. And the last one is interlink between CSO representative in the 2 committees and the subcommittee and the board-based CSO network at grassroots level, for which problem and concern are seamlessly transmitted from local to policy decision, which ensure effectiveness of the UC scheme. Only the CSO representation in committee member is identified by law. Another 2 levels of citizen participation were the implementation beyond the provision in National Health Security Act. However, the research found that this phenomenon can happen because citizen participation is the main concept behind the scene of the law and a strong implementation of the provision that mandate the representation of civil society organization as a committee member in the National Health Security. The outcome of citizen participation includes successful expansion of service in the benefit package and strong public ownership of UC scheme through surveillance, protect, promote, and support implementation of UC scheme. For the discussion part, we try to explain this phenomenon by this theory that shows how 3 levels of citizen participation in UC scheme work to move the better outcome for UC scheme, especially on the expansion of the necessary service in the benefit package. After the literature review, we agree with the definition of professional empowerment as defined by Alishwa Sadhan. She defined professional empowerment as an intervention to encourage process of individual and community empowerment. In the case of CSO representative in 2 boards, under the National Health Security Act, seems like an intermediary between individual level and policy level. This interlinkage ensures that the voice of people are transmitted to policymaker and the information from the policymaker is regularly transmitted to the citizen. We learn from this research as the legal provision as essential, but effective implementation of legal provision is more essential. To achieve this, there needs National Health Security Organization's strong intention to implement professionally capable CSO serving 2 boards, various subcommittee, working group, and interaction with community level board-based CSO interaction. And the last point is identification, weakness, and improvement of civic participation in UCS. For good governance of USC legislation in low and middle income countries need an adequate representation of CSO in its governing bodies and related functions for which citizen voice are heard and remedial action are taken. And B, strong CSO function safeguarding public interest, not CSO own personal interest. That's all from our research. Thank you for your attention.
Thank you very much. Fascinating presentation that gets at the heart of this challenge of moving from saying the right things, signing the right acts, creating the right legal provisions to actual implementation that brings about the spirit of the legal system and the provision. So I'm sure that everyone's got a lot of questions. Please do use the Q&A feature as you think of questions. We'll be collecting them and then discussing them at the end. We'll now hear from Ms. Hadija Khan, who will present a systematic evidence mapping review on health system responsiveness, mapping the conceptual and empirical literature.
Good day. Thank you for your interest in our research on health systems responsiveness. This review forms part of a larger project on health systems responsiveness in Kenya and South Africa. And the aim of the project to understand how feedback is given to systems, how it is processed, as well as how systems respond to the feedback. This is a collaborative research project between the University of Cape Town, the University of the Western Cape, and the Kenyan Medical Research Institute. So the World Health Report broke new ground, framing responsiveness as a performance indicator, along with good health and fair financing. The report emphasized responsiveness to the legitimate expectations of populations and individuals, specifically stressing the importance of reducing inequalities and improving the situation for the worst off. Responsiveness is therefore thought to relate to the protection of human rights and is considered important to improve the health outcomes of populations. So 2 decades later, after this conception, there is a greater focus on calls for fair financing and equity as compared to calls for making systems more responsive. We also find that there are still major concerns and questions around the aspects of responsiveness, various aspects of responsiveness, including the framing. Is it just accountability? Is measurement of responsiveness broader than patient satisfaction? And how do we, and in practice, what does a responsive system look like? And how do we create that? We also found that the evidence is not collated sufficiently for researchers and practitioners to use the evidence base and also to develop the responsiveness literature further. Given these gaps, the aim of the evidence mapping that we conducted was to map the current state of knowledge on health systems responsiveness and then ultimately to identify the gaps. We conducted the review using the 4 recommended steps, and the first was to determine the scope of the question and the scope of the review. And we did this by doing an initial scoping review and also consulted with HPSR experts on health systems responsiveness, governance, and accountability. The second step was then to search for and select relevant items. And this was done through systematized searches using 3 databases, EBSCOhost, PubMed, and Google Scholar. We also did some hand searches, and the searches were conducted from July until September 2019. Inclusion criteria were peer review items, or peer or institutionally reviewed items, and then also items that included a specific conceptual or empirical information on responsiveness. Exclusion criteria involved physiological or biomedical responses to medication or treatment, and responsiveness that was framed as psychometric properties, and items that we could not find the full text for. For us to be able to map and report on the findings, 608 items were included for full text. We were interested in the bibliographic mapping as well as the dominant ideas pertaining to responsiveness for us to be able to identify the evidence gaps. So to give you a sense of the bibliographic characteristics of the health systems responsiveness evidence base, we found that there was a surge of publications at the start of the 2nd decade. And you can see that at the end of 2010, there were 80 items, and the surge, there's a surge of 197 between the first 5 years in that decade. We were also interested to look at responsiveness in terms of the responsiveness literature in terms of low and middle income countries, and also focusing on, we were particularly interested to find out that there were only 9 items that looked at fragile states. We also looked regionally at where responsiveness literature was emanating from, and we found that Europe was the forerunner, with the majority of the publications emanating from Europe and focusing on European populations. With regard to the nature of the contribution made to the evidence, body of evidence, we found that the majority of the publications were empirical and much fewer were conceptual in nature. And so to give you an idea of the dominant understandings of responsiveness, through our analysis, we identified 3 underpinning ideas that were related to responsiveness. And this is just to give you a feel of the landscape, and it's not a rigid classification system that we've used. And so the first one is a user service interface. This categorization comprised of 24% of the evidence base. Responsiveness here is understood as a quality checking and a service improvement indicator. And this categorization was strongly influenced by the WHO conceptualization. This categorization suggests that responsiveness is aimed towards patients who has accessed care and are still in the system. The second categorization is service feedback between users and the health system. And this categorization comprised of the largest proportion of the evidence base. Responsiveness is understood as processes to obtain and respond to feedback at the service level. This categorization specifically suggests that responsiveness is aimed towards various users, including patient and patient representatives, as well as those who are seeking care and those who are not yet in the system. The final categorization was the categorization that frames responsiveness as a broader issue of accountability. And this categorization was 31% of the evidence base. And here, this categorization encapsulates internal and external accountability, and it suggests that responsiveness be aimed not only at users, but at all populations and communities within a particular health system. So to give you an idea of the observations, or to give you just to highlight some of the observations that we made through the review, we can see that there is continued and growing interest in health systems responsiveness, despite the this conceptualization of responsiveness being slow to gain traction. We see that there are theoretical and empirical gaps, specifically that responsiveness is inadequately developed as a concept and a theory. And we see that through the review, it does not provide us conclusive answers to the framing and theorization of responsiveness, given that from the previous slide, you see that there are multiple framings of responsiveness. So matched with the theorization, we also realized that we need to develop more tools to assess health systems responsiveness, which is the empirical work that we hope to see happening, and for responsiveness to be measured over time, given the fluidity of health systems. We particularly suggest a distinction to be made between service responsiveness and health systems responsiveness, where a systems lens allows for the consideration of the expectations of a broader systems actor in terms of populations and not just users, and a systems lens allows for the consideration of responsiveness across building blocks and the interactions between building blocks. And so these are some of the observations that we've made. If you are interested, the manuscript will be submitted at the end of middle to end of October, and so please look out for that. Thank you very much.
Thank you, Hadija. It's really interesting to hear about that distinction between the responsiveness of the health service to the user and responsiveness to the citizenship more generally, especially in light of what we learned about Thailand, to think through what is happening with their citizenship, citizen participation in their health services, and how it kind of shakes out how much of it is about direct user accountability and responsiveness and how much of it is broader. So it'll be interesting to discuss that. I hope people are flagging some questions in the Q&A. Don't be shy. And I'll now welcome our final presenter, Mrs. Evelyn Waweru, who will speak about exploring patient-centered care approaches to empower patients and improve health system accountability, a qualitative study in rural Eastern Uganda.
Hello, everybody. My name is Evelyn. Please join me in exploring patient-centered care approaches to empower patients and improve health systems accountability. This is a qualitative study in rural Eastern Uganda. To begin with, there are many definitions to patient-centered care, but there are specific elements that make it a promise for accountable health systems. It is a care system that is customized to patients and family preferences and values, where information is shared freely and patients and families are taken as part of the care team and are involved in making decisions, both clinical and non-clinical. In the wider context, it's a health system that incorporates patients' views in quality, so that they become quality improvement drivers and policies remain realistic to the context. With this in mind, PCC advocates for activated and empowered patients who would in turn improve expectations and demand for good quality healthcare, improve community engagement and participation, and become a good resource in managing their own illnesses, especially with the rise of chronic diseases and, for example, in the current pandemic where patients take more time at home and need to take more responsibility for their health before going to health facilities. PCC also looks at patients as partners and involves all relevant stakeholders in order to encourage ownership and improve sustainability. It also emphasizes that research should amplify the voice of the patient by considering their experiences in evidence-based policymaking and practice. All this is with the aim to make sure that health systems are accountable financially, in terms of performance, and also in terms of political and democratic accountability, where patients hold health systems and government responsible for the utilization of resources and for promises that have been made and agreed upon targets. In understanding patient-centered care in Uganda, we had a mixed method study with 3 objectives: to explore stakeholder perceptions, to describe whether and how patient-centered care is incorporated at primary healthcare level, and to explore current challenges and opportunities. This was with the aim to inform both the scientific community but also the stakeholders in the promise of PCC, collaborate with them in designing interventions, and empower them to ensure sustainability long-term. The study was conducted in 2 districts within the Iganga Mayuge Health Surveillance Site. We selected 6 health center level 3, including both public and private facilities, and we focused on patients receiving curative care. The information for this study is extracted from 31 semi-structured interviews and 5 focus group discussions. So our initial findings was to identify the stakeholders, and we found that while patient-centered care is centered around the patient, it's not only about the patient. It also includes the interactions with health practitioners within the context of a consultation, the interaction with family, village health teams or community health workers, and patient support groups within the context of a health facility, and within the larger health system. There are other stakeholders like health educators, district health managers, the Ministry of Health, and donors. However, it's important to note that while they interact indirectly with these stakeholders, the health worker is an important part of the direct interaction between the patient and the actors in the wider health system. There is therefore a need to move all the identified stakeholders from a siloed disease-focused mindset to a more patient-centered one, manage the complex interest and influence of the different stakeholders in order to develop a common understanding and vision for patient-centered care. So to look at it in more detail, we borrow from the Donabedian framework of structure, processes, and outcomes, and we look at it from an accountability perspective, but also from a health system accountability perspective and a patient-centered perspective. So to begin with, the precursors to PCC would be patients who take responsibility for health, have good health literacy, are aware of patients' rights, but also a health system that provides access to health services and encourages patient and caregiver improvement. In order for this to happen, then there's need for open dialogue with stakeholders to inform patients about policies in the design and also the implementation stage and incorporate their voices. In terms of processes, it is important to consider the flexibility of patient choice, the communication processes, the ease of information sharing in both directions, and also shared decision making. But this can only be possible if there are strong patient-provider relationships with encouraged trust, empathy, and cultural competency. An example of this is when you look at eye contact and kneeling in the Ugandan context. Eye contact is a sign of disrespect, while kneeling is a sign of respect. So as a person coming in from the outer context or as a health worker, they need to be trained to pick up these interpersonal skills that would lead to underlying power dynamics. There's also a need for clear and appropriate channels for conflict resolutions. Lastly, the outcomes are hopefully that there would be a community that has trust and confidence in engaging with the health systems, has positive interactions, improved self-efficacy and assertiveness, and also improved patient satisfaction. But this will only make sense if these recommendations that are given by the patients are actually taken into account. Some considerations that are specific to low and middle income countries or low resource settings are the awareness of the challenge of making patients adequate partners, including an existing threatened identity and over-reliance on health practitioners, which creates some information asymmetry. But despite this, in our study, patients understood patient-centered care, even if they didn't call it that, and expressed a demand and preference for health workers with patient-centered qualities and fast and effective health systems. So in order for PCC to work in such a context, it requires building responsive and resilient community health systems where patients' voice is amplified by involving them in representative groups as opposed to individuals, so that they can have a greater voice in policy making, service delivery, and administration. There's also a need for the co-design of interventions in order for patients to be involved in contextualizing the indicators of progress, what is success and what is failure, and the evaluation of interventions. There's also need for training for health workers on interpersonal skills and the provision of psychosocial care in addition to physical and clinical care. And lastly, in terms of research, there is need to develop and validate methods that adequately measure patient-centered care in low and middle income contexts. Thank you for your attention. I would like to acknowledge the funders and participants in this study. Thank you for listening and enjoy the rest of your conference.
Thank you, Evelyn. So we'll now, I think, invite the speakers who are with us, Evelyn, Hadija, and Kamanwan, to turn their videos on. And we'll move into the Q&A and discussion component of the session. So I'm just looking in our Events on Air platform. We don't have any questions from the audience, which is fine. It gives me a chance to ask some myself, but I do want the participants and audience to not feel shy, and please do provide any questions. Also, if you just want to reflect in the discussion forum, you don't want to pose a question, but you just want to reflect on how this work triggers your own thinking for your own research, or some salient points that came out for you, please do note that in the discussion forum. And just to add that the speakers who could not join us live, that's Emma and Jose, they will be able to access this recording and see the discussion and the questions. So if you do have things you wanted to say to them, feel free to indicate that here, but they obviously won't be able to respond during our session now. Okay, so I think what I would just want to do to start us off is provide one sort of question for each of you and invite you to reflect, and then we can return for another round based on what we see come up in the Q&A. So Kamanwan, you spoke really, it was fascinating to hear this movement from legal space to actual use of that space by CSOs. I was wondering if you could speak a bit more about which citizens occupied that space and which citizens stepped up to take part in these deliberations and these acts of accountability, especially around what sort of motivates these people to join these community, the civil society organizations, and maybe even to discuss a little bit about the accountability of these CSOs themselves, because I think one critique that government has often put up around increasing these types of spaces has to do with the fact that CSO organizations are not elected, and how do we ensure that they are accountable? So if you could just comment on some of these issues of which citizens occupy that space and their own identities and accountability, that would be really interesting. I also want to welcome Emma. I'm so glad you could join us live. So please, audience participants, do feel free to ask Emma questions too. So that was Kamon one. For Hadija, I was just wondering, so it was fascinating to see that about 1/3 of the literature did take this broader view of accountability, and the other 2/3 seemed to be more about the patient-provider relationship and the quality of care given to the individual patient. I was wondering if you could reflect a little bit more on the literature that framed accountability more broadly and speak to us about, was this examples of accountability initiatives on a pilot scale level or at scale, or what did you kind of find in that section of literature that focused on accountability more broadly? Evelyn, you were speaking about some of the antecedents to patient-centered care. And I was really struck by some of the points you made about the type of patient that can really assert themselves and benefit from this model. And thinking about some of the work I've done, primarily in rural northern India, we found a lot of the women were not really fulfilling these antecedents. They themselves did not have a strong articulated desire to be stakeholders in their care. They really spoke about wanting a doctor to tell them what to do, and that's their job, and why would they ask me my opinion? And they weren't really used to being asked their opinion about a lot of things. So I was wondering if you could talk a bit more about how you see the general population in these areas you did your research on, being able to, hold up that side of the patient-centered care, or whether patient-centered care needs to be adapted to a different type of population. And Emma, I didn't quite prepare a question because you popped up, but it's great to see you. I was wondering maybe if you wanted to just reflect. I assume you were watching some of the presentations already. And one thing that I noted when I was looking at your framework was I was kind of using the example from Brazil to understand your framework and to see how the examples that Jose presented would fit into your framework. So I want to know maybe if you could speak a bit about applying that framework, whether you have applied it or how you would like to see people apply it. All right, so I'll turn it over to Kamon One.
Hi. Okay, I would like to respond the question. The first question is about which citizen that participate in this model, right? Okay. We can say that we have many level of citizens that participate in this model. In the citizen that work to be the board member, and another one is a citizen who are the working in the sub board, that's a working group and sub committee, and the other is the citizen who in the outside of two boards. But if the question is how we ensure that our citizen that not participate in this can participate in this model, I think when we talk about the third one of frame that we talk about, that we call them the citizen, they are the networking that around the country. They have the network in the region, and they have the networking and they have the communication between the network. So we can say that they have a platform to talking together with the network, and so that communicate their concern and their problem. So Yes, in our study, we don't have the access or how many people and how many citizens that involved in this model, but we can tell that we have more than citizens that attend in the board who participate in this model. Yes, and is clear or not?
No, I think that's very helpful. I guess I was even just wondering, in that citizen participation space, like how can they make sure that lobbyists don't enter that space or people with private interests in pushing some sort of pharmaceutical product don't enter that space? Like, how do they make sure that the citizen groups that use that legal framework are genuinely interested in supporting citizen health?
Yes, but in another way, and we have more than one channel that citizens can participate in this model. This focus of paper just like talk about the CSO, but actually for the UCS in Thailand, we have many channels that citizens can voice their concerns, like annual public hearing and 1330 helpline, that's 24-hour service. They can respond, they can voice their problem all in many channels. Yes.
Okay, that's very, it's very helpful. It's not just this one mechanism. There are actually a huge range of engagement.
Yes, and from the mechanism like mandate in the legal provision, that's why we discuss the legal provision is the first step to open the channel for citizens to participate.
Thank you. Hadija, would you like to speak a bit more?
Okay, so the aim of our review was basically mainly to identify what is within the body of evidence, and so just a disclaimer that part of this review was not to look quite closely at these different clusters or categorizations. So I can give you some information on the body on accountability, and so what we did find was that there was a bit of a mix between the external accountability and internal accountability, and more particularly there was within this cluster a subcluster that focused on mechanisms, and so there were items that were empirical and there were items that were conceptual, and so at some levels there were regional mechanisms. So you could see that it was with either in a facility or within a region, for example a province or a county, and so just some examples of the mechanisms that we found, accountability mechanisms that somehow also resemble what we call responsiveness mechanisms were the health facility committees and boards. We also found scorecards that accounted for 12%, and so they in some of these it was more about designing these tools. There were also items around measuring how these can improve health outcomes, even accountability or community participation outcomes. And so, for example, the scorecards was about measuring the implementation and measuring the effect of these mechanisms. And community monitoring was something that was 7%. So the majority of the items looking at accountability were the health facility committees, and here it was about legitimizing health facility committees within the different community, within the different health systems or facilities. It was also about describing some of the processes and functionings of these facilities, and then also the final cluster that was with regard to that was measuring the impact of health facility committees on health outcomes, participation, and then also strengthening accountability. And so, yeah, there was that blend where some of it was more about methodologically designing these mechanisms, but then there were items that were more specifically, particularly it was at a regional or facility level. There weren't many more upscale national items that I can, off the top of my head right now, recall, but those are some of the few. Is that
No, that's
good
very
enough?
helpful. Yeah. And I think that speaks a lot to Martina Lambani's question, who had asked, are there any specific channels used for community groups to interact with the health system? And you've listed a number of the ones that you identified, the scorecards and committees. And her follow-on is, how well do these groups operate and what are some of the challenges? And I think that might be beyond the scope of the review you spoke of, but it kind of gives a starting point of the types of mechanisms that exist. And Martina, just to add that you can see from both Jose and Kamonwan's presentations, those are two additional examples of mechanisms. So there's the Brazilian councils, and there's these specific citizen spaces mandated by the Thai system. So I think that was really a helpful response, Hadija. I'll invite Evelyn to reflect as well. Evelyn.
Thanks, Carrie. So one of the questions was what type of patient would be able to participate in unaccountable health systems. And you're right, for our initial finding was that most patients don't want to be involved, and looking at it from a patient-centered angle, which is going beyond the patient as a person who has a disease to a patient who has a background, a family, psychosocial aspects and social economic aspects that affect their health and their illness when they're in the hospital. We found that as far as, so I'll give an example. For example, like something like stress. Patients did not recognize that stress is something that you should talk to your healthcare provider about, and they deflected sort of to family or a community health worker or something like that. While in actual fact, stress can actually contribute to physical or clinical illness. So creating awareness in patients that they're supposed to talk about their whole situation can give an even, so it's about making the patient an able partner, because the doctor will know more about the clinical disease, but the patient will be the expert about their situation once they leave the health facility. The other thing that we found is that, for example, in the context where we worked, patients were actually walking around with a patient book that had information about all their clinical diagnoses, all the medication that they've taken, but they don't understand what is in the book. And when we asked them, would you like to have understood what's in the book? The answer was a resounding yes. So there is a demand for knowledge about their health and their healthcare. And for example, in the context now of a pandemic where most people are afraid to go to hospitals, then it would make more sense, especially for those with chronic illness, to empower them to be able to take care of themselves more at home and only access the health services when it's absolutely necessary. I'll also take this opportunity to answer one of the questions in the chat about patient-centered care and the responsiveness of health systems. So patient-centered care is more about the interpersonal relationship between a patient and the health system. So it's more about improving the quality of care, not in terms of clinical perspectives, but in terms of how the patient interacts with the system, so how they're treated, and also the way in which they're treated. So looking at things like trust, looking at things like empathy, which would also improve the patient's ability to be able to contribute to evaluate the system or the services that they receive. So that's how I see the connection between patient-centered care and responsive health systems.
Thank you very much, Evelyn. And thank you for taking that second question as well. Emma, would you like to comment?
Sure. Hi, and nice to see everyone. Yeah, so I'm not aware of sort of any government or program that sort of used the framework in its entirety and in a kind of a prospective way. If anyone is, I'd love to hear about it and hear how it's working. But I think there have been examples of sort of using parts of it, maybe not always kind of intentionally, right? But thinking about sort of examples where there's been a very deliberate consideration and costing about how to optimize the health workforce, whether that's kind of between facility and community and the skill set and supervision, et cetera, that's kind of needed across both, right? And I don't even want to make it binary, but sort of across the different levels. Or whether it's really, and I think that some of the examples from today sort of show the intentionality of the health system in saying, where are those spaces for social participation and civil society in kind of formal ways. And I think one of the things I've been thinking about recently and hearing a lot of people's work in this area and some of the responses that patients and citizens are giving is thinking about, like, what is the balance between shifting power a bit more and the flip side of kind of that added burden, right? So how much are we asking patients to take on and understand? Or, you know, we want community members to be holding facilities accountable, right? But is it their job to be, you know, monitoring it like day by day? And so kind of thinking about that balance. And so part of that then to me comes back to maybe there need to be sort of more multiple ways to have that voice and that participation, because I think, as we've heard, some people are more comfortable with certain kinds of formal counsels. Some people are more comfortable with, you know, one-time feedback on their experience specifically with the health system. And so I think, you know, trying to be intentional about understanding what those preferences might be and knowing they may be quite varied as far as the way that people can give feedback. So I think sort of thinking about those different pathways is helpful for thinking about how different components of the health system in the broadest sense, right? So including the users and civil society, et cetera, kind of interact with the formal aspects of it. And I'm hopeful that this framework allows more of that kind of thinking to move sort of beyond what are these very narrow kind of pillars into what are some of these more dynamic aspects that happen. And I think the other thing that we're hearing a lot of is kind of that by making changes or sort of pressure in certain aspects of the system can put pressure on kind of the system as a whole to be more responsive. So again, I sort of haven't heard a lot about using this kind of framework necessarily from the top, but maybe kind of bottom up pushing for some of these changes in some of the aspects that then might have, you know, ripple effects or might put pressure on other parts of the system to consider kind of where community role might be not just kind of valuable, but actually essential for its functionality. Thanks.
Yeah, that's really helpful, Emma. And I think in some ways, this set of presentations in this session sort of highlight that multi-pronged approach to accountability that you're getting at, because we have like Evelyn's sort of direct patient-provider relationship, and that's going to have its level of accountability, its level of feedback, its level of trust. And then you have the health councils that Jose talked about in Brazil, which are like a institutionalized mechanism, and they're at the community level. And then you have the like civil society, the official space held by civil society organizations in Thailand, and they're seeming to be at quite a high level in the system. And so it's kind of like there are different models for pushing, but I don't know if we have any system in the world where they've kind of maximized all the prongs of accountability. I think that we have enough time for everyone to take maybe a 1.5 minute final closing thoughts. And I wanted to draw on Mina's question, which I thought was really powerful. She really is talking about resistance and the fact that like accountability, it's easy to talk about it in a very sanitized manner. But it's actually, there are a lot of interests at stake and there's a lot of power at stake. And in India, she's highlighting that when the government tried to introduce Clinical Establishments Act, which would actually rein in some of the power, the medical associations really banded together hard against this and they went on strike. And that echoes what has happened in other countries. I'm from Canada, and I know in the 1970s when they introduced universal health coverage here in Canada, the doctors went on strike and so this will ruin us. And so there is sort of direct physician desire to be less accountable in certain ways and to protect their interests. And then there's systems level interests all the way up through elected officials and into the bureaucratic structures with a lot of issues of corruption. So I was going to draw from Mina's question about resistance and managing resistance and overcoming resistance. She's kind of talking about ways to reorient the physicians themselves so that their energy is harnessed towards a more just system or other ways to handle resistance. Alternatively, please do feel free to comment. I think Mark had asked a question about measurement. So if we are trying to improve accountability and track this, what are the tools that we can use to measure? So I'll just give everyone actually 1 minute to give some closing thoughts to either discuss resistance a little bit or measurement. And I'll start with Kamanwan. Please go ahead.
Yeah, it's very interesting question, but I think there are many mechanisms that should balance about the voice from the professional and the citizen. Actually, in our board, CSO is a part of many sectors of board. So we try to balance this in the board and in every mechanism. Like I know public hearing that we have the voice from professional and have the voice from citizen also. We have a National Health Security Office who take responsive under this law and try to balance the voice from health professional and citizen. I think this is very mechanism. Thank you.
Thank you. Hadija.
Okay, so I think I'll speak to a bit about the measurement of accountability. And so there are various ways of measuring accountability. I'm more particularly around, well, for me, the external accountability cluster of mechanisms are quite important. And specifically, I'm thinking the community monitoring, and I think something that Emma has raised is about, placing that burden on the more on communities. But I feel like measuring accountability according to my understanding and how that links to responsiveness, it's ideally how are we framing accountability? Are we looking at what are we looking at the are we sorry, I'm just going blank, sorry. So when we want to measure accountability, I think the best way to do it is, obviously it's somehow mentioned before, is co-producing and co-designing measures that are actually acceptable with communities and user groups, and let me not use user groups, but just populations of interest and whose concerns are actually at the center. I think for me that is the biggest, is designing that, because I've just recognized that it's about we're pushing for ownership, but also the way Evelyn has been speaking about these specific types of groups of people that are more open to taking on that role, whereas there's maybe passive groups. So yeah, I think it's about things that are acceptable to those who want to hold others accountable, the system accountable.
Thank you so much, Khadija. Evelyn.
So specific to managing the resistance from health workers, I completely agree with that comment, because it's difficult to change the way that people do things unless you show them the benefit of it. So for example, if you ask, in the context of my study, if you ask a health worker to spend 2 more minutes asking about what's the situation at home, are you able to cope with this diet, are you able to buy your medication? If you put it as a top down or an additional requirement, then you'll face resistance because of the time that they have, and they see it as additional work for them. But if you front it as something that if you do once, then the next time it makes your work easier, it becomes more acceptable. And what we found also to be helpful is having the interaction between the groups. So we would have interactions for health workers on their own, patients on their own, but then at some point you bring some health workers and some patients together so that they can see different perspectives and they can be empathic about each other's situation. At a more muscle level, so beyond the health facility, it was a bit more difficult to get, for example, health managers to come down to the patient's level, but I think that will take time. And as of now, most countries are starting with making the policies for advocating for patient rights and creating more awareness, but how that will turn out in implementation depends on the particular context. Then in terms of measuring accountability, I agree with Hadija, and I think the comment that I would make on that is that that is also very contextually determined. So we have the formal tools that would have so indicators for financial accountability, performance, what is required, but then we need those to be contextualized in the environments that we work, and also learn from each of the other contexts.
Thank you, Evelyn. And Emma, please close us out with a 1-minute comment.
Sure, thanks. And I should also say I can't see the chat from my window, so if people had other comments, please do follow up. I know these sessions always feel too short. But I think from kind of a broader view, I won't speak to the specifics about resistance, but just to say that I think kind of using a more inclusive and dynamic framework lets us think about these interactions not as being linear, right? So not just about, how do we improve this sort of single pillar top down, what are the barriers to uptake, but really think about what are the various kind of inputs and interactions that affect those, and those might include stakeholders that aren't often thought about or are often kind of seen as being in certain alignment, but actually have different agendas and needs, and maybe if those needs are met in one way, then they're less resistant in another. And I think that connects to the idea of measurement, which is also to say that the sort of need to move beyond coverage also allows us to think about what are the more, not more, but what are the other important things that we need to be measuring, and that by really thinking about the sort of aspects around trust and accountability and who is asked and who is involved, tells us a lot more kind of about the health system. And so in this framework, actually, we consider data and accountability together, right? And so the idea of kind of data collection, not for its own sake, but for the sake of improvement, becomes even more important than when you say who should be looking at it and using it and helping design what gets collected. And I think when you talk to users and community members, their questions about the system may be less about, what does this cost the state, and maybe more about how do we improve, my trust and respect and interactions with providers or sort of, micro level kind of interaction sort of things. And so the people who need to be involved in that design need to be there from the beginning. And I think that's how we see these cycles, really improve across kind of an entire framework rather than just at specific points that then don't kind of speak to the larger system.
Thank you, Emma. I think that's a fantastic note to end on, and it really speaks to the broader question of the session of like, what does it take to build this at scale? And I think the idea of building your measurement, building your indicators, and building your systems using the population and the community voice to actually decide what is important and what role they need to play, and then creating multiple avenues for participation is really crucial. So thank you, everyone. And I'll close for today, and do keep the conversation going on Twitter and in other forums.